much, Lori. Hi, thanks everyone for joining us. And today we're going to be talking about biomarkers, which is a very hot topic, and how to use it in clinical practice. So I don't have any conflict of interest. And a little bit of the themes of the day. We're going to be discussing the role of a little bit of the history of biomarkers. We're going to be discussing tau and amyloid. What happened with the trajectory of biomarkers and how the biomarkers could change as the disease progressed, and how we use biomarkers in clinical practice. And we are going to show you a very simple patient that we saw at CMN to try to illustrate how much biomarkers could help in this case. And as Lori says, let's try to make this interactive. And if you have questions, you could email me and we talk over. Good. So let me pass the presentation. Okay, so a little bit of what happened with biomarkers over time, just a very brief history. In 1906, Dr. Alzheimer's described the first patient that we know that have Alzheimer's disease. This is a very famous patient, and her name is Augusta Deter. And at that time, Dr. Alzheimer's named this disease as pre-senile dementia. Nothing really happened in the field, until 1980, where we start calling Alzheimer's disease with Alzheimer's disease. And in 2004, in this trajectory, let me see if I can get the laser, that's good. We finally have some biomarkers, and we were able to understand the pathophysiology and to see the pathophysiology of Alzheimer's without using an autopsy or a biopsy. That means that now we have this possibility of doing biomarkers when patients are doing the trajectory of this disease in vivo, and we can do some not so complicated biomarkers. So the discovery of the biomarkers and the use of biomarkers in clinical practice really changed the continuum and how we nominate Alzheimer's disease. And after this, we have different nominations. And now, with the incorporation of biomarkers, now we can talk about preclinical Alzheimer's, minimal cognitive impairment due to Alzheimer's disease, and dementia due to Alzheimer's disease. And we're going to be describing a little bit by these biomarkers. So let me pass the slide. A little bit of remembering of the pathophysiology of Alzheimer's disease. We have two main findings. We have amyloid, which is an extra neuronal accumulation of a normal protein that in this, to form these neuritic plaques, is folded in a different way. And this is extraneuronal, and we have this graph here where we see the deposit of amyloid in between the neurons. And then inside the neurons, we have this accumulation of hyperphosphorylate tau protein. Tau is a normal protein that is part of the normal axon and dendritics of the neuron and helps with the cytoskeleton. But this tau protein gets an extra phosphorus in one of these positions and then accumulates and forms these tangles inside the neuron. And eventually, this combination of amyloid accumulus and tau tangles inside the neurons leads to neural damage and neuronal death. And this is what we see down here. So again, the pathophysiology, extraneuronal amyloid plaques, and intraneuronal neurofibrillary tangles. So the biomarkers are based on amyloid and tau. So let's go to the next one. So let's review a little bit the name of minimal cognitive impairment. So minimal cognitive impairment means a patient that could have some memory complaints. I could do a screening test and I could have a normal result or a little low result, but that patient is absolutely normal in their functional status. So that means that the cognitive changes didn't really affect the cognitive status in any way and the functional status. But when I do a full cognitive assessment, I see that at least in one cognitive domain, the results are below 2 standard deviation of what it should be normal. So when I have such a patient, again, screening test could be normal or a little decrease, functional assessment is absolutely normal, and full cognitive assessment and see below 2 standard deviation on at least one cognitive domain, I can say that this patient has minimal cognitive impairment. So if we see here in the graph, the usual continuum of Alzheimer's disease, it goes from normal cognition to early minimal cognitive impairment to late minimal cognitive impairment. And then once we have impairment in the functional status, we could talk about mild dementia. And then that progresses to moderate dementia and severe dementia. So again, this is very important. This limit is the functional impairment. That's why we spend time in every visit as a memory specialist to try to determine the exact degree or lack of degree of functional impairment. Good. So really biomarkers, and I really like these slides from the Alzheimer's Association, they are really changing the game, okay? So we have here an amyloid PET. We could be talking about biomarkers in blood, biomarkers in CSF, but this is really has been the main discovery in this field in the last 20 years. And now with these new anti-amyloid drugs that we are starting to have in the market, we really need to select the right patients who do have Alzheimer's disease pathology. So these new anti-amyloid drugs, they really go along with doing biomarkers and knowing exactly which kind of disease I'm dealing with. So that's why I like this slide. This was really a game changer, okay? So if you remember this slide, this one is really interesting from the Alzheimer's Association group. This is like a theoretical model where we see patients who progress over time, and this here on the XY from preclinical disease, that means they don't have symptoms, to minimal cognitive impairment, and as the disease progresses to dementia. So depending on when and which time of the disease I'm doing the biomarkers, I could find different biomarkers. So the first thing that happens is that we see accumulation, and this is this red curve of amyloid in the brain. And the first finding is that when I measure amyloid in the liquid, in the CSF liquid, that measurement is decreased, and that means that that amyloid is getting stick into the brain. Okay, so the first finding is decrease in measurement of amyloid in the brain. The second finding that happens a few years after, and this is the orange and then the green curve here, is that we could see some synaptic dysfunction, and then the green one means that we have some tau pathology. So depending on when I'm doing the biomarkers, I could find that the patient has positive amyloid but negative tau, depending again on the trajectory of this disease. As the disease progresses, we have the violet curve, and this is when we're going to see some decrease inside of some critical memory parts of the brain. And then finally, the patient has symptoms, and then the last curve, which is the brown, is when we have clinical symptoms and decrease in functioning. So all this data also came from this cohort study called DIAN. These are patients who have a different form of the disease. They have an hereditary form of the disease, and they have autosomical transmitted Alzheimer's disease. So they have the genes, and since the penetrance is very high, if they have the gene, we know that most likely 90% of the cases, they will have the disease. So in this clinical trial, this is part of the DIAN study for patients with a genetically transmitted Alzheimer's disease. So they follow this cohort of patients who have no symptoms from the time they were 20 until for the next following years. And what they were able to see is that many years before they had the onset of symptoms, we start seeing biomarkers in the brain. It could be as early as 25 years before, when we see the decrease in the measurement of beta amyloid 42 in the CSF. And 15 years before they have the onset of the disease, we can start seeing accumulation of amyloid in the brain. And this is what we see here down in this picture, where we have from this cohort, from this population, they have patients who have the genetic mutations and patients who didn't have. These are called the non-carriers. And if you see, many years before they have the onset of the symptoms of the disease, at least 15 years before, they start to have an accumulation of amyloid. And you see the accumulation of amyloid with this kind of yellow of orange. And then by the time we diagnose the disease, they already have all these deposits of amyloid here in the cortical area and also in the subcortical. And then 10 years before the disease, we start seeing decrease in metabolism in some critical areas and decrease in cognitive tests. So again, this is very interesting data, and that's how we learn. This was published at least 10 years before. That's how we learned that depending on when I'm doing the biomarkers, I could find different results. But again, it showed the same. Decrease amyloid in the CSF, increased tau in the green curve here, and finally here when we say 0, which is when the patients are diagnosed with the disease, at this time they already have a hypometabolism. So all this data was very interesting, and it really helped us understand the trajectory of the biomarkers in the brain through time. So this is a little graph of which kind of biomarkers we can order. So we could do a CSF tab, and we could do a measurement of beta amyloid, the 42. We could measure the total tau. We could measure the hyperphosphorylate tau, and we could do some calculations. And this is now something new. We could also do a measurement of neurofilaments. So depending on which biomarker I'm doing, I'm going to obtain different results. So of course, if I'm doing amyloid and tau, those are markers for the pathophysiology, because I'm showing that we have increased amyloid and increased tau in the brain. If I'm doing a structured MRI, I'm not going to have an idea of the pathophysiology, but I'm going to have what we call topographic markers. So by the time I see decrease inside of the hippocampus, this is a topographic marker, but this is many years after the amyloid was accumulated in the brain. So again, here on the right, we have markers of amyloidosis, we have markers of tau, we have topographic markers that usually correlate better with the symptoms and the severity. And now we also have the possibility of doing these neurofilament light chain measurements in CSF. And now the new thing are the plasma biomarkers. So I think that in the next future, we will be able to diagnose the pathophysiology markers of Alzheimer's disease by doing plasma biomarkers. So that would be much easier. And there is a lot of new information coming on that field. So let's go to the next one. So this is just an example of the amyloid for a PET for amyloid, where, as I said before, we see the deposits of the amyloid as orange and red and yellow accumulus in the cortical areas. This is to differentiate a patient who has Alzheimer's disease versus a patient who has no Alzheimer's disease. And this amyloid PET has been validated, again, autopsy, and the concordance of having amyloid in your brain, if you have a positive PET, is very high, okay? Now, in the recent years, we can also do marker of tau using PET. And this is something new that happened a few years ago. And as you can see here in the graph, we have a patient with Alzheimer's versus a control, and we see accumulation of tau protein. And what's interesting with tau in that there is some spread of tau from one area to the other. So if you follow these patients in time and different patients, you could see the spreading of the tau. So tau, as with amyloid, when we do a PET for tau, we had a very high sensitivity too against autopsy results. Good. I don't know, Lori, if there is any questions, or we keep on going. How are we doing?
No questions in the chat yet. If
Okay.
anyone has a question, please feel free to come unmute.
Good. So we talk a little about pathophysiology markers. We talk about the PET with tau and with amyloid. We talk a little about what we can measure in the CSF. And of course, we have neuroimages. And as I said before, the neuroimages and the specifically focus on the medial temporal lobe are topographic markers and also markers in a way of severity. So you will see that when we order an MRI on dementia, we usually don't need to add contrast, but we always want to see the coronal cut to focus on the hippocampus, okay? And you will see that when you order an MRI on dementia, in the report, you have this scale called MTA, that means medial temporal atrophy scale, and it's actually nice to be able to know where this is coming from. So let's review in a few seconds what happens with the hippocampus as we age. So here on the left, we have a stage of 0, which is absolutely normal. And here is the hippocampus. I'm actually pointing this with my laser. And this is the height of the hippocampus. And we have this kind of very narrow space, and this is called the choroid fissure. And we have almost this virtual space, and this is called the temporal horn. With normal aging and also with Alzheimer's, we see a decrease in the height of the hippocampus and a widening of the size of the wide of the choroid fissure. So here, first graph, we have an MTA of 1, where we see this fissure going a little further and the height of the hippocampus a little shorter. Again, this could be normal depending on age. As the disease progresses or as the individual ages, we could see an MTA of 2. Again, the hippocampus is getting shorter and this fissure is getting wider and the temporal horn 2. And then that progressed to a stage of 3 and finally a stage of 4. So stage 3 and 4 of the MTA is always abnormal. 1 and 2, depending on the age, it could be normal. So here I just put examples of MRIs with the MTA, where again, we see the hippocampus here, really nice and tall. This is normal, MTA 0, MTA of 1, MTA of 2, we see this widening of the choroid fissure. MTA of 3, the whole height of the hippocampus is really shortened. And finally, the final stage, MTA of 4. So having this MRI and these coronal cuts really helps to try to understand what is going on with the hippocampus. So when do we order these biomarkers? And I think this is very important. So we definitely want to order if we're dealing with early onset dementia. And by definition, we talk about early onset dementia is when patients present with cognitive symptoms before they turn 65. So most likely, if we have cases of early onset dementia, we may want to consider doing biomarkers. When we have young patients with minimal cognitive impairment, that helps to predict the risk of progression, so we may want to offer that. When we have cases that are really atypical on presentation, they may have focal deficit, they may have Parkinsonian features, they may have like an atypical presentation of Alzheimer's with cortical posterior atrophy symptoms, or I may have a patient who presents with language problems that could be in the spectrum of primary progressive aphasia. So this is not typical Alzheimer's disease. So I may want to consider doing biomarkers to try to really understand what is going on and the pathophysiology. And finally, and this is very important, if we're going to offer anti-amyloid drugs to a patient, I need to show that they have the pathophysiology of Alzheimer's. So definitely I need to show that they have amyloid. And in the last trial that was just presented a few days ago with the news agent that is still not approved by the FDA, they also want to show that the patient have tau pathology. So these are the cases where most likely we want to consider adding biomarkers. This is an old slide, but I think it's interesting. This is the describe here, the appropriate, published by Johnson in 2013, that describe the appropriate use of PET, and it's actually very similar to what we just said. Okay, so again, atypical cases, we may consider patients with early onset Alzheimer's and patients with MCI. Very good. So now we're going to spend the last 5 minutes, and then we will leave some time for questions or comments. I just want to describe a patient that I saw here at Social Memory Net, and a case where I think that biomarkers are useful. So this is a man who presents, he's 71. He presents with short-term memory loss that started about 2 years ago and is slightly progressed over time. The patient is repetitive. He started to use calendar reminders, different strategies, so he could be able to continue to function independently. He uses a shopping list, he drives without any problems, and when we do the functional assessment, he's independent in all his basic activities and instrument activities. So we do past medical history, hypertension, and well-controlled diabetes, no history of dementia. His educational level is 12th grade. He completed 12th grade. He had no other past medical history, no side history, denies depressive symptoms. We do a focused neuro exam, so he's oriented exam 3. He's fluent with a fluent language. His behavior is appropriate. He has a normal neuro exam with no focal deficit, and his gait is normal. So we first usually start with a screening test, and the MOCA is part of our cognitive assessment, and it's a very good screening test. So we could see here the MOCA of the patient. Overall, he scored 23 out of 30, and he was oriented, as I say, no problem with that. He was able to name the animals okay, but he has some problems with the rhino. He's a hypo. He had some problems drawing the clock, and in this MOCA, what he really lost all his points was for his short-term memory. So in the MOCA, we teach them a list of 5 words, and once they learn it, then we distract them, and then we actually check for the delayed recall and to see how much they remember. So this patient was pretty amnestic, so he couldn't remember any of the words. So we decided to go ahead and do a full cognitive exam. And this is how the kind of protocol that we do here at Social Memory Net. So, and this is how you will see the reports on EPIC. And so this patient had a MOC of 23, as I said before, and he didn't have a lot of problems in executive function. He didn't have any problems on visuospatial. His attention span was very good. But we see here on the right that he did have problems remembering a list of 15 words, and this is called the Ray Auditory Learning Test, and I'm going to show you what it means. And he also had problems on visual memory, remembering a complex figure, and he had no language problem. So we could see from this full cognitive assessment that his main problem was memory. Okay, so this is I wanted to show you this test that we do. This is called the complex Ray figure. So we ask the patients to copy this figure. As you can see here, he did it very well. Then we distract them, and then we ask him what they remember. And in this case, his visual memory was decreased, and he couldn't remember a lot. And the second test that we do for memory is called the Ray Auditory Verbal Learning Test. So what we do here is we read a list of 15 words, and we ask the patients to see how many of them they remember. And we do this 5 times. So we read the same list 5 times, and we could see here that the patient remembers 6 words, 6 words, 6 words, 7, and 7. So he had like a good recollection, immediate recollection, and he was able to learn 1 more word. Then we distract them, and then we go back after 30 minutes. We do this other test, and then we go back after 30 minutes, and we could see here in this column, which is called A7, that he could only remember 1 word. So the conclusion from this cognitive test is that this patient had amnestic MCI. This is his MRI. This is the sagittal view in T1. We see the patient has some mild parietal atrophy. This is the T2 with flare. He had no vascular lesions. And this is his coronal cuts that, if you remember what we just described, the MTA, he has very mild hippocampal atrophy. Here is his hippocampus. This is probably an MTA of 1. So I decided with this diagnosis of amnestic MCI, and since he's young and he was interested in knowing his risk, I decided to order Alzheimer's disease biomarkers. So in this case, we decided to do a spinal tap, and we found the results that he had a decreased level of beta 42, he had an increased level of tau, he had an increased level of phosphotau, and sometimes we use this ratio with this formula that we put together the total tau and the beta 42. And what we see here is that this patient really had the typical pattern of Alzheimer's. So he did have accumulation of amyloid in the brain. That's why the measurement in the CSF is decreased. And he did have increased neurodegeneration with increased tau. So after having these results with biomarkers, now I can say that this patient has amnestic MCI due to Alzheimer's disease, because I found Alzheimer's disease pathology. And this patient, if he doesn't have any contraindications, no microbleeds, no severe vascular disease, a microvascular disease that I show you the MRI that he didn't have, he could be a candidate for anti-amyloid therapy. So with that, I'd like to conclude. I know this is a lot and it could be a little long. If you could please fill the survey, and in the last slide, there is my email if you want to ask me any other questions. And now I open the discussion, Lori, to if we have any comments or questions. And thank you so much for your attention.
Thank you so much, Dr. Cohen. That was a lot of great information in a short amount of time. And I love the—
It's a lot. I'm sorry. Maybe it's a lot. Maybe we can do some other lectures if the audience is particularly interested in biomarkers with more cases. Yeah.
It was great, though. And the case presentation was great. We do have just one question. Will we have access to the slides after the presentation? So I will send out the slides as well as a recording, and also the link to the evaluation survey. So you all get
definitely that. You have that. Yeah, no problem with that. Yes.
All right. Are there any other questions before we log off for the day? All right. Well, thank you everyone for joining. Again, please make sure you complete the evaluation survey, especially if you're wanting to receive CME credits. And we hope that we will see you all next month for our next session on August the 18th at noon. I'm sorry, okay. August the 16th.
August the 16th. Okay. And we're going to have also, when are we scheduled to see neuroimaging with Dr.